Before we discuss diseases of particular systems, we are going to spend some time discussing how the body responds to tissue damage. We are going to discuss some of the body's innate mechanisms of protection. Although these processes are thought of as protective, they have the potential to cause disease or harm when the responses are either inadequate or excessive and uncontrolled. The first one we are discussing is inflammation. Inflammation is a protective device intended to eliminate the initial cause of cell injury. It is triggered by physical trauma, various types of wounds, infection, and tissue necrosis. It usually starts to occur before an immune response begins. Inflammation also helps with the removal of necrotic tissues that may result from injury. This happens so that healing can take place. Our body has three lines of defense. The first line is made up of barriers that keep pathogenic organisms out. The second line of defense involves the inflammatory response. The inflammatory response is activated at the site of tissue injury. There are two types of inflammation, acute and chronic. Acute inflammation is usually triggered by injury or infection. Fluid accumulates at the site and various cells such as neutrophils come to the area. Acute inflammation is usually of fairly short duration. When the infection is removed or the wound is healed, inflammation disappears. Chronic inflammation can last for months or even years. When this happens, fibroblasts will be drawn to the area and often scar tissue will form. Several serious diseases such as arteriosclerosis, some forms of arthritis, and some lung diseases are made worse by chronic inflammation. We will first consider what happens with acute inflammation. Inflammation occurs in vascularized tissue and produces the 5 classic signs of inflammation: redness, heat, swelling, pain, and loss of function. There are 2 stages of inflammation, the vascular stage and the cellular stage. We will be starting with the vascular stage. Inflammation occurs in vascularized tissue and occurs almost at once. It starts with changes in circulation. The small vessels constrict briefly and then dilate. This brings more blood to the area, and redness, increased warmth, pain, and swelling will occur. The next thing that happens is the increased permeability of the blood vessels. Chemicals, such as histamines and nitric oxide, cause increased permeability of the vessels, and fluid, known as exudate, starts to leak out. This helps to dilute the toxins. This fluid also causes swelling, pain, and impaired function. It also means that the blood in the blood vessels becomes more viscous because of a loss of fluid from the blood, and this causes some coagulation, which helps contain the microorganisms. Biochemical mediators such as histamine, bradykinin, leukotrienes, and prostaglandins stimulate the endothelial cells in the capillary walls to retract, creating spaces between the cells. White blood cells migrate out through the walls of the blood vessels. This picture shows what happens after the endothelial cells in the walls of a blood vessel retract. Here we see diapedesis, also known as transmigration. How fast these vascular changes occurs varies depending upon the severity and type of injury. The changes may happen quickly and disappear within a few minutes, or the changes may continue for days with more severe wounds. In the case of radiation injuries such as sunburn, the effects may not begin for several hours. There are 3 basic patterns of inflammation. Intermediate transient response occurs with minor injury. Inflammation develops rapidly and lasts only a short time, usually 15 to 30 minutes. It usually involves only the small venules. This is the type of reaction we might get if we scratch our arm. The second type of reaction is immediate, sustained response. It happens following more serious injuries and continues for several days. It affects the arteries, the venules, and the capillaries alike, and is a result of damage to the endothelium of the blood vessels. In the third pattern, delayed hemodynamic response, the increased permeability does not begin for 2 to 12 hours following the injury. The inflammation lasts for several hours or even days. This pattern is usually found after radiation injuries such as sunburn. Now let's think about the cellular phase of inflammation. During the cellular phase, two things are happening. Leukocytes are moving to the area affected, and chemicals are being released from the tissue cells that are affected by the injury or infection. There is a definite sequence to what is happening with the leukocytes. Margination is when leukocytes begin to accumulate along the edge of the blood vessels. Chemicals called cytokines are released that cause the leukocytes to adhere to the endothelium of the blood vessel. This adhesion causes the endothelial cells lining the blood vessel to separate, which allows the leukocytes to move through the wall of the blood vessel into the tissue spaces, also known as intercellular spaces. This movement is known as transmigration. Chemotaxis occurs because the leukocytes will be attracted to the area of injury or infection by chemicals that are secreted by the injured cells and by the cells of the immune system, such as macrophages. The leukocytes will follow the concentration gradient to the source of the chemicals. In the last step, macrophages, monocytes, and neutrophils are activated to engulf microbes and cellular debris by the process of phagocytosis. This is accomplished by the phagocyte using recognition molecules and receptors to bind to their targets. The complement system may play a role in this process by coating the target cells with a chemical which makes it easier for the phagocyte to bind to the target. This coating is known as opsonization. Now let's consider some of the cells that are involved in inflammation. Endothelial cells make up the single layer of cells lining blood vessels. They release various chemicals that attract leukocytes and cause them to adhere to endothelial cells. Other chemicals released by the endothelial cells contribute to inflammation by causing dilation of the capillaries. In addition, endothelial cells synthesize and release chemicals which cause inflammation, stimulate cloning, and the growth of cells involved in the immune response. They release growth factors that stimulate growth of new blood vessels as repair processes occur. Mast cells are located in places where they are apt to come in contact with antigens. They are found in large numbers in the skin and lining the gastrointestinal and respiratory tract. Thus, they play a major role in initiating the inflammatory response. Mast cells contain a large number of granules. When there is some sort of injury to the cell, these granules release various chemicals, such as histamine, which causes dilation of blood vessels and also causes inflammation. Neutrophil chemotactic factor and eosinophil chemotactic factor are also released from mast cells, and these chemicals attract neutrophils and eosinophils to the area. Mast cells will synthesize various mediators of inflammation, such as leukotrienes, prostaglandins, and platelet activating factor. Leukotrienes cause the contraction of smooth muscle and increase the permeability of the blood vessels. Prostaglandins will also cause increased vascular permeability and smooth muscle contraction. And maybe you remember that prostaglandins can be inhibited by aspirin and other NSAIDs. Platelet activating factor not only causes the aggregation of platelets, but it also simulates the development of inflammation in a variety of ways. Neutrophils make up about 60 to 70% of all of the leukocytes. They are granulocytes, and their granules contain enzymes which will help break down engulfed microbes and debris. Neutrophils are the predominant phagocytes in the early stages of inflammation. They start arriving at the site of injury within 90 minutes. They are attracted to the site and activated by chemotaxis. They respond to some of the chemicals in complement, chemicals from mast cells, and bacterial proteins. This brings them to the area. They also produce hydrogen peroxide and nitric oxide, which will help break down pathogens they have engulfed. As leukocytes, they are capable of diapedesis and are highly mobile. They are incapable of cell division, and they will be affected by the acidic environment at the inflammatory site. The result of this is neutrophils will be dying in great numbers. They have a life expectancy of only about 10 hours, and following their death, they become a component of pus at the site of the injury. Here we see a neutrophil doing diapedesis or transmigration and then acting as a phagocyte. The granules contain antibacterial enzymes that will help break down bacteria they have engulfed. They also produce hydrogen peroxide and nitric acid that will kill engulfed bacteria. Eosinophils make up only about 2 to 4% of the leukocytes. They too are attracted by chemotaxis and usually arrive at the site of injury in about 2 to 3 days. Eosinophils have two specific functions. They serve as the body's primary defense against parasites, and they help control allergic reactions produced by the chemicals released from mast cells. This keeps us from developing more inflammation than is needed. They do this by producing an antihistamine enzyme. They also detoxify foreign proteins by forming an antibody-antigen complex with them. Some of the granules of eosinophils contain a protein that is highly toxic to parasitic worms. Because eosinophils are relatively long-lived, they often play a role in chronic inflammation. Here we see an eosinophil attacking the covering of a parasitic worm. The chemicals that are released help digest the surface covering of the worm. At one time, we thought that basophils change into mast cells. There is no longer agreement about this. Many people think they just come from the same stem cells. And I mention this just in case you are lying awake at night wondering about where the mast cells come from. Even though the numbers of basophils are relatively small, they play an important role in the inflammatory response. When immunoglobulin E binds to basophils, this triggers the release of histamine, and histamine causes the dilation of blood vessels, thus contributing to inflammation. The heparin they release helps control blood clotting. Macrophages become more active once they leave the circulatory system. They usually arrive at the inflammatory site 3 to 7 days after the initial injury. They are attracted there by chemotactic fasters released by neutrophils. They have a fairly large capacity for engulfing and destroying foreign material. Unlike the granulocytes, they can survive and divide in the inflammatory site. Thus, they become very important in destroying the cause of the inflammation and in promoting the healing process. They secrete growth factors that promote healing. Because of their relative longevity, they play a major role in chronic inflammation. Macrophages are activated by cytokines and lymphokines released by T lymphocytes. Here we see that happening. Macrophages have surface receptors for cytokines and once activated become more effective killers of infectious microorganisms. Macrophage activation results in increased phagocytic activity, increased size, and an increase in the number of lysosomes. Macrophages will also secrete factors that stimulate other inflammatory cells as well as start the healing process. Monocytes make up about 3 to 8% of the leukocytes. If they leave the circulation, they become larger macrophages. Those that remain in the blood have been linked to some inflammatory disorders such as arteriosclerosis. While we usually associate lymphocytes with reduction of antibodies, B cells and T cells, they also play a role in inflammation, especially with chronic inflammation. Macrophages display antigens to T cells, and this activates the T cells. The T cells, in turn, produce chemicals which stimulate the macrophages that will present more antigens, etc. This can set up a cycle which will sustain chronic inflammation. Once an injury occurs, thrombocytes are activated by several different chemicals. Activation starts the various processes for controlling bleeding and causes thrombocytes to release chemicals from their granules. These chemicals include coagulation proteins and adhesion molecules. Other chemicals increase vascular permeability and enhance the inflammatory response. Several diseases such as lupus and arteriosclerosis are associated with inflammation caused by chemicals that are released by activated platelets. There are several chemicals that contribute to inflammation. We are going to consider some of them. Preformed histamine is stored in mast cells, basophils, and platelets, and thus is ready for a quick release, making it one of the first chemicals released in acute inflammatory reactions. Histamine causes dilation of the arterioles, which increases blood flow to the area. It also increases the permeability of the venules. Exudate forms and swelling results. The effects of histamine depend upon the receptors on the target cells. The H1 receptors on smooth muscle in the bronchi causes bronchiolitis vasoconstriction. The H2 receptors on the mucosal cells in the stomach causes increased secretion of gastric acid. Anti-inflammatory drugs often work by binding to these receptors. Bradykinin is part of a group of plasma proteins known as kinins. Their primary role is to activate and assist inflammatory cells. Bradykinin is activated by clotting factor 12. It causes dilation of blood vessels, acts with prostaglandins to increase pain, increases the permeability of the blood vessels, and increases leukocyte chemotaxis. Bradykinin also increases permeability by causing retraction of the endothelial cells in the walls of the capillaries. As a result of the effects of bradykinin, the endothelial cells have retracted, and we see diapedesis or transmigration occurring. The complement system is a plasma-derived mediator for inflammation. The complement system is made up of several plasma proteins. It is activated by antibody-antigen complexes, by chemicals released by bacteria and fungi, and by other plasma protein systems. Complement is very important because activated components can destroy pathogens directly and can also activate other components of the inflammatory response. Complement is nonspecific. It has four main functions. They include aiding phagocytosis by causing opsonization, where pieces of complement stick to the surface of a pathogenic or microorganism and make it easier for the microorganism to be engulfed by phagocytes. Complement acts as a chemotactic factor for neutrophils. Third, it contributes to inflammation by causing vasodilation and increasing vascular permeability. And fourth, some components of complement form complexes which will cause pores in bacterial cell membranes. This leads to cell lysis. This diagram just shows some of the components of complement which will cause the various functions. You do not have to know these chemicals or the steps. Arachidonic acid is a fatty acid found in cell membranes. When something disturbs the cell membranes, arachidonic acid is released, and it will take part in a series of reactions that will lead to the production of prostaglandins or leukotrienes. There are two chemical pathways for the development of arachidonic acid metabolites. One pathway leads to the formation of leukotrienes. Leukotrienes are rather slow-acting and will cause the contraction of smooth muscle in the bronchioles, for example, increase vascular permeability, and serve as chemotactic factors for neutrophils and eosinophils. A second pathway produces prostaglandins. They also increase vascular permeability, induce inflammation, and are chemotactic factors for neutrophils. In addition, they will cause platelet aggregation and act as vasoconstrictors. Aspirin and other NSAIDs will inactivate the first enzyme in the pathway which produces prostaglandins. You do not have to know these pathways, but you will want to know what the two end products are and what they do. Oxygen-derived free radicals may be released by leukocytes that have been exposed to cytokines or microbes, or they may be released during phagocytosis. The effects of these free radicals depend upon several things, including the presence of other chemicals that are produced by inflammatory cells. These free radicals have a tendency to amplify the cascade that causes inflammation. The local manifestations vary greatly depending upon the severity of inflammation, the cause of the inflammation, and its location. These manifestations can vary from some redness and a slight amount of swelling to so much swelling that it impairs the functioning of the tissue, or to the formation of abscesses and/or ulcers. Many times, the normal inflammatory reactions made by our immune system may be more damaging than the original microbe. Typically, exudates are produced as part of the inflammatory response. They vary greatly in composition. Serous exudates are watery fluids containing only a small amount of protein. They develop as a result of plasma leaving the capillaries. Hemorrhagic exudates occur where there is severe damage to the blood vessels or a leakage of erythrocytes from the capillaries. Fibrinous exudates contain a large amount of fibrinogen, and they will form a mesh similar to a blood clot. Membranous exudates develop on the mucous membranes, and they contain necrotic cells. Purulent exudate contains dying leukocytes, proteins, and cellular debris. We commonly call this material pus. An abscess usually consists of a core of purulent exudate surrounded by a layer of neutrophils. Often it will be walled off by fibroblasts and will need to be drained. An ulcer develops when there's a large number of dead and dying cells on an epithelial surface that is being eroded away. Regardless of the cause of inflammation, the outcome usually is one of three processes: resolution, progression to chronic inflammation, or substantial scarring and fibrosis. Resolution involves the replacement of severely damaged cells and the return of the tissue to normal form and function. There is no permanent injury. Progression to chronic inflammation may occur if the cause of the inflammation is not removed. Depending on how much damage is done by the chronic inflammation and the ability of the injured tissue to regenerate itself, chronic inflammation may be followed by restoration to normal structure and function. Scarring and fibrosis will occur if the tissue is unable to regenerate or if there is substantial tissue injury. Superficially, the difference between acute and chronic inflammation is one of duration. Acute inflammation is usually self-limiting and lasts 2 weeks or less. Chronic inflammation may continue for weeks, months, or even years. If bacterial contamination or foreign objects such as splinters, sutures, or dirt remain in place, supination and incomplete healing will be typical of this type of chronic inflammation. Chronic inflammation may develop following acute inflammation, or it may develop as a result of a low-grade persistent infection or irritation. It can be caused by the presence of injured tissue. Some microorganisms, such as mycobacteria that cause tuberculosis, have lipid cell walls that make it difficult for phagocytes to break them down. Other microorganisms, such as those causing leprosy, syphilis, and tuberculosis, can survive within macrophages. Chronic inflammation is characterized by a large number of neutrophils and macrophages. It is also characterized by angiogenesis, the formation of new blood vessels in the area, and fibrosis, as our body attempts to repair damaged connective tissue. Chronic inflammation can result in scarring and fibrosis. Chronic inflammation may occur as a result of tissue damage from some long-term diseases such as arteriosclerosis, arthritis, and inflammatory bowel disease. The presence of material like asbestos, silica, talc, sutures, viruses, fungi, and some bacteria may cause chronic inflammation. There is a possible link between obesity and chronic inflammation. Adipose tissue has been shown to release chemicals which cause inflammation. So what is bad about chronic inflammation? Chronic inflammation can cause changes in DNA that can lead to cancer. It can also create an environment that is conducive to tumor formation and growth. In addition, chronic inflammation can cause scarring and fibrosis, which will interfere with normal tissue function. There is a distinctive type of chronic inflammation which involves the formation of a granuloma. A granuloma is formed when the body is trying to wall off an infection. It consists of a mass of macrophages surrounded by lymphocytes. There is usually some type of foreign material in the center of the granuloma, such as a splinter, suture, microorganism, or an inorganic substance such as asbestos or silica. The walls of the granuloma often contain collagen. The cells inside the granuloma may coalesce into a large, multinucleated giant cell which will try to surround the foreign object. As the cells in the granuloma die, enzymes are released and liquefaction, necrosis occurs. Eventually, the fluid will diffuse out, and we are left with a hollow, thick-walled structure which may remain with us for the rest of our lives. Our body temperature is regulated by the thermoregulatory center in the hypothalamus. Chemicals called cytokines can change the set point of this center, resulting in an elevated body temperature, which we call a fever. Things that can cause fevers are known as pyrogens. They can be chemicals released by microorganisms, injured or abnormal cells, and some malignant cells, such as those of leukemia and Hodgkin disease. Some pyrogens target the hypothalamus. Others cause host cells to release cytokines that act as pyrogens on the hypothalamus. The purpose of fever is not completely understood. However, it does serve as an indicator of health. Many times it serves as a signal that we have an infection. Fever is not harmful unless it rises to high levels. Fever actually assists the body in fighting infection. The increased temperature retards the growth of microorganisms. It also increases the activity of leukocytes and stimulates the formation of the chemical interferon. When we have a fever, the liver and spleen will remove iron and zinc from the blood. This will slow down the growth of many bacteria. Fever also increases the body's metabolic rate, which aids tissue repair. The development of fever can be divided into 4 successive stages. Not everyone experiences all of these stages. Some people do not sweat, and others have no chill or shivering. The first, or prodromal stage, involves vague complaints like a mild headache, fatigue and malaise, and fleeting aches and pains. During the second or chill stage, there is a feeling of being chilled, and the person may experience shaking or shivering even though their fever is rising. This usually begins with vasoconstriction and piloerection. The skin will be pale and covered with goosebumps. When shivering has caused the temperature to rise to the new set point, shivering will stop and the person will have a feeling of warmth. At this time, the third stage, or flush, begins. Vasodilation of vessels in the skin will occur, and the skin will become warm and reddened. The last stage, defervescence, begins when the person starts to sweat. Defervescence comes from the Latin word meaning to grow cool. Some of the common manifestations of fever include anorexia, myalgia, fatigue, and arthralgia. Respiration and heart rates usually increase, and there may be dehydration because of the sweating. An increase in metabolic rate and the need for more oxygen will increase the energy needs of the cells. Cells may process more proteins and fats, and this can lead to metabolic acidosis from the increased breakdown of lipids. An increase in the appetite suppressor, leptin, has been found to be associated with the presence of fever and inflammation. Headache is mostly caused by the vasodilation of blood vessels in the brain. In the elderly and others with poor pulmonary function, this lack of oxygen can result in confusion, incoordination, and agitation. Febrile seizures may occur in some children. A rise in temperature can activate the type 1 herpes simplex virus and cause the development of a fever blister. It is not always easy to determine the cause of a fever. Sometimes there are prolonged fevers where the temperature is 100 degrees for 3 weeks or longer. These are called FUOs, fevers of unknown origin. They can be caused by malignancies, infection, and cirrhosis of the liver, among other things. Let's talk a little bit about the treatment for fever. The purpose of modification of the external environment is to facilitate the transfer of heat from our body to our surroundings. For this purpose, we can use sponge baths, cooling blankets, or mattresses. We must take care, though, not to cause shivering or vasoconstriction, which would defeat our purpose of removing heat from the body. A second thing we should do is to give adequate fluids and nourishment. Fluids are needed to prevent dehydration from the sweating and increased respiratory rate. Additional fluids may also help with the transport of heat to the skin. A diet high in simple carbohydrates will help provide the additional energy needed because of the increased metabolic rate and help prevent tissue breakdown. Antipyretic medicines such as aspirin and acetaminophen will help reset the temperature control center in the hypothalamus. They will also help alleviate some of the discomforts associated with the fever.